Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on physician payment systems entitled Pay for Performance, Part 2. This module is targeted to Level 3 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe the drivers of initiatives to increasingly base physician payments on a variety of quality and value metrics, to outline the history of Medicare's physician pay-for-performance initiatives, and to identify tactics to optimize individual physician success under current and anticipated pay-for-performance models, and inform the development of more robust future models by payers and professional societies alike. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. We talked previously about the evolution of physician payment systems from fee-for-service to pay-for-performance and accountable episodes, and our plans to present each of these framework models to you in a series of modules. In Part 1 of this two-part session, I introduced you to pay-for-performance, particularly as it pertains to physician payments under Medicare. We'll continue that discussion in this second part of that module series. You may remember I defined for you pay-for-performance. It's a form of value-based purchasing which financially incentivizes provider behavior using bonuses and/or penalties that can be either graded or binary, in which payments are dependent on specific service characteristics that are desired by the payer. And that list usually includes outcomes, appropriateness, service, and cost. Why those? Again, because as we have previously discussed, these are all components of value, and pay for performance is a value-based purchasing program. We talked about the evolution of Medicare's physician payment methodology from usual, customary, and reasonable to resource-based relative value scale, and to the various different forms of pay for performance: PQRI, PQRS, and MIPS. Those last three, Physician Quality Reporting Initiative, Physician Quality Reporting System, and the Merit-Based Incentive Payment System, represent the progression of pay for performance for physicians under the Medicare program. You may remember that this evolution started in 2007 with PQRI, then a voluntary bonus program that morphed into PQRS, an initially voluntary bonus program that evolved into a mandatory penalty avoidance program, and then formed the basis of MIPS, in which losers will pay winners, with a total Medicare payment adjustment from physician to physician ranging from -9% to +9% of RBRVS. That's a gap of nearly 20%, and so the financial performance stakes become quite high. The problem with all of these systems, as I indicated, however, is that there aren't really currently reliable, validated, and transparent methods in place for measuring value in radiology. And so the metrics are largely based on surrogates of quality. And so Medicare pays not as much for the quality of your care, but rather than for the quality of your reporting. That means that a lot of this is still box checking. But structured reporting makes that all a lot easier and sets you up for success under the programs currently in place. And I think allows you to develop an infrastructure for more seamlessly reporting more meaningful metrics as they are developed and implemented in the future. Historically, and still largely at present, those metrics have been process-based. That is, did you comply with a particular process of interest? That's because it's so hard to measure downstream outcomes with regard to what we as radiologists do. Here's a list of measures that may be familiar to you as part of template fields at your institution. These are the big measures for radiologists under the PQRI and PQRS programs. And here's an example of a former template of mine when PQRI rolled out. The sentences in red here are the ones where I had a forced function must insert field in place to remind me at the end of a long and busy day that I need to get those things into my report. And you know by now, I'm a big fan of structured reporting for compliance with ICD requirements, CPT requirements, and as well for pay-for-performance requirements. And so when PQRI rolled out, I knew through self-audits that because of my template use, I was 100% compliant. Well on my way to receiving my maximum bonus. Or so I thought, as I'll tell you about a bit later. Medicare's pay-for-performance programs have been in place for a little bit more than a decade now, and so we do have some early experience to share. Let's spend a few minutes and answer each of these questions that you see listed here, because all of these potentially have relevance for your success as these programs continue to evolve. Is it worth participating? How do radiologists perform? What factors influence their performance? And can I just ignore this all? Is this all worth it? Important question. And that's a question I asked, and my 29 physician practice partners asked about a decade ago when we were early and aggressive adopters of PQRI. With 1.5% of our dollars on the table, we implemented a variety of educational initiatives to get our doctors and our coders all up to speed, and operational initiatives to make sure that all of our measures got reported to CMS through our claims. But it didn't work out nearly as well as we would have liked. In the first year of the program, only 1/3 of our physicians received a bonus from Medicare. And in the second year, we did even worse. Only 1/5 did. As the lead physician adopter of PQRI, I was shocked to find out that I did not receive a bonus. Again, I did not receive a bonus, even though I personally had been preparing for this program before most radiologists knew it was even coming about. And despite a number of inquiries, I still can't find out today from Medicare why they didn't give me my bonus. What this all means is that our practice overall got only less than 0.5% bonus from Medicare practice-wide. But when we surveyed our physicians and asked them, how much work did it take you to do all this stuff? They reported that on average it took 3 times as much as that to comply. And really disappointingly, they overwhelmingly didn't think that any of the PQRI requirements in any way helped them provide better care. You see our conclusions here from our paper. Even when aggressively pursued, PQRI yields actual physician bonuses far less than those expected, more than an order of magnitude less than the requisite incremental physician work, with little perceived impact on quality. It's a pretty pessimistic reflection of the early program. And our practice's experience was not dissimilar to others. When we looked at radiologists more broadly, we found that only 1/4 of radiologists received a bonus from Medicare. But as the bonuses increased, going from PQRI to PQRS, those that did get bonuses did pretty well, on average about $2,800 a year. That's not chump change. But we do need to take all of these measures with a grain of salt, particularly as Medicare is proposing rolling out more and more. Here's some work we published about how a variety of specialties do across a variety of measures that CMS has tracked. You see that some specialties have performed really well, depending upon the metric, and some pretty poorly. And this makes the case that these measures cannot be one size fits all. We need to have measures that apply to individual specialties and, in fact, individual subspecialties, and that make sense for both those doctors and their patients. Some yet unpublished work that we have underway shows that there are huge disparities in how radiologists perform under these systems. In 2015, the most recent year for which CMS has at present released data, only half of all approximately 30,000 U.S. radiologists have reported these quality measures to them. And we saw higher scores in radiologists who were in larger practices, perhaps related to the more robust reporting infrastructures of those practices. We saw higher scores for those who were more subspecialized and more academic, which may be related to the very narrow and nuanced nature of those measures. And for reasons we can't immediately explain, we interestingly found better performance in the program by younger radiologists rather than older ones, and by female radiologists compared with males. The large practice advantage is something that CMS knew about and predicted in advance of MACRA. It's a lot of work to educate your physicians and your coders and to get enrolled in registries. And so the agency predicted that larger practices would get bonuses about 81% of the time, as you see here in the lower red box. And the smallest practices, here in the red box, the solo practices, would get penalties about 87% of the time. Given the voluminous participation requirements, if you're going this alone, you're probably not going to do very well. Some radiologists have looked at some cursory data by CMS and determined that they don't have to participate in MIPS. But that's not the case in reality. There are a bunch of different reasons radiologists are required to participate in the program. And many have to do not with what they do individually, but with what their partners do, because most of these are reported on a group basis or a tax ID basis. We're predicting that MIPS will apply to some 97% of radiologists. So for almost all of you, pay for performance will not be optional. And so you may be asking yourself, again, back to my original question, based upon my experience from over a decade ago as well, is this really all worth it? And I would submit to you, I think it is. Medicare has estimated that it will cost each physician on average $723 a year to participate in the program and take 11 hours each year of his or her time. That is not insignificant. But as we'll talk about in the macro module down the road, the difference in Medicare payments between high performers and low performers will be almost 20% when the program is fully rolled out in 2022. 20% of a radiologist's salary is a lot of money. But this isn't just about the money. Over time, all of these metrics will be made public. So when a patient looks you up online, do you want to have them see you as a 1-star doctor or a 5-star doctor? And so at the physician level, I think it's clear that participation is worth it. But let's step back more broadly. While it seems intuitive at the societal level that pay-for-performance initiatives are worth pursuing, the jury is still out a bit. Focusing on the value-based payment modifier program, a program by which radiologists participate by simply reporting in the PQRS program, something sort of wonky that I didn't already burden you with. In a random sample of 20% of Medicare beneficiaries, Roberts and colleagues recently threw a wet blanket on the huge societal enthusiasm about pay-for-performance initiatives. They concluded that the value-based payment modifier program was not associated with differences in performance on program measures, and the performance differences between practices serving higher risk and lower risk patients were affected considerably by additional adjustments, suggesting a potential for Medicare's pay-for-performance programs to exacerbate healthcare disparities. What does that mean? It means that this program incentivized physicians who care for patients with less favorable clinical and socio-demographic factors at the expense of those who need their physician services even more. That's certainly not what we want to incentivize. What this all means, I think, is that there are still many devils in the details that need to get worked out. If we're going to incentivize behavior, we need to make sure that we're incentivizing the right kind. Remember the perverse incentives that we talked about with fee-for-service a couple modules ago? Pay-for-performance will not be immune to those. Ultimately, I would encourage you in your own practices to follow the advice of General Patton. Lead or follow, or at least get out of the way of your other partners as they try to make this all work. Simply saying, no, I don't want to do this, is not a good option for your payments or your professional reputation. And that leadership is a message that your professional societies get as well. Remember, we talked about advocacy in a prior module, and I just showed you that Medicare's current pay-for-performance programs aren't yet where they need to be. Rest assured, though, a lot of work is going on advocating for better metrics for radiologists as MIPS continue to roll out. Let me share with you an example. One measure that has received a lot of attention by the lay press, as well as CMS, is the so-called double scan rates. What's that mean? Well, a without contrast CT scan is considered a single contrast, as is a post-contrast CT scan. Double scans in the quality vernacular are CT scans performed both without and with contrast, that is, a double scan. The thinking was that these were widely utilized, and that this overutilization was associated with increased radiation doses to patients, as well as costs related to the higher valued services. and so as part of its hospital outpatient imaging efficiency metrics, a pay-for-performance system that applies to hospitals and not physicians, CMS started tracking double scan rates by hospitals and publishing them. The public scrutiny forced hospitals to pay attention to this metric, as did the modest facility pay-for-performance adjustments they saw for improving their rates. But even though it is physicians who are protocoling these examinations, CMS only applied these measurements to hospitals and not the radiologists, and sometimes non-radiologists, who interpret these examinations. When we looked at double scan rates for abdominal CT scans billed by radiologists and non-radiologists, we found some pretty fascinating results. You see double scan rates here by non-radiologists over time in blue, and rates by radiologists in red. When CMS started talking about this measure around 2006, double scan rates by non-radiologists were already much higher than those of radiologists. And over time, as the measure was implemented, you see there wasn't really much change at all in the behavior of non-radiologists, whereas radiologists improved their performance pretty dramatically. When we last looked at this, double scan rates by non-radiologists were about twice as high as those of radiologists. That means lower dose of radiation and also lower cost. And that's why the ACR's Policy Research Group and Economics Advocacy Group have separately studied and advocating for aligning these CMS metrics and making this hospital metric apply to its partnered physicians. If we really want to change behavior, we need to align incentives so our hospitals and our physicians are all rowing in the same direction. There's still a lot of work to do, but I think this case highlights the opportunities for identifying meaningful metrics and working to implement them in practice. And it's another example of the important advocacy work our professional societies do, and again, why I encourage you to support those organizations as members with your dues, as well as with your volunteer time. We'll talk about another value-based purchasing model, accountable episodes, in our next module. In summary, physician pay-for-performance is a form of value-based purchasing intended to incentivize higher quality and lower cost care. Despite theoretical appeal, like fee-for-service, such payment models are not without some challenges. At present, Medicare's pay-for-performance systems reward physicians more for the quality of their reporting rather than the reporting of actual quality. Given clear stakeholder imperatives and increasing dollars at stake, radiologists must work to make participation as meaningful as possible at both the individual practice but also the broader society level. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the RIPLEAD initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to you continuing along your economics and health policy milestones journey. Again, thank you for participating in RIPLEAD.